Good evening. Thank you for joining me. My name is Brian Lamb. I'm a physician assistant out here in Northern Virginia, just about 20 minutes outside DC at Inova Health System. And tonight you're here with us on GAP's MASLD MASH Community Network, and we will be talking about MetALD, which is MASLD fatty liver plus alcohol use. And this is sponsored by the good folks at Madrigal, so thank you to them. We just have a couple of participants online tonight, so some of you will be maybe watching this recorded, but for those who are on tonight, if you want to jump in at any time, I'm glad to have conversations here. So feel free to just jump in, and if you know something I don't, feel free to jump in and teach me something. But again, like I said, I'm a physician assistant. I've been working in liver disease for about 20 years here at Inova Fairfax Hospital. If you would like to record your attendance for this meeting, you can scan this QR code, which I'll show again at the end. And let's just, and briefly, I'll just say MASLD Community Network is a great place online to network and get good education just about MASLD and fatty liver in general. You can follow your favorite providers in the region, and it's a great place to find your favorite education leaders from GAP. So let's start with the case tonight. This is Ashley. She comes into your office. She's 52 years old, and she had an abdominal sonogram showing some steatosis and some mild hepatomegaly, and she feels fine. This is kind of our typical patient coming in for a MASLD or fatty liver evaluation. You note there that her BMI is 29.4, which is pretty good compared to most of the patients I see, but yeah, so not technically obese, but pushing it. She has a medical history of polycystic ovarian syndrome, hypertension, and hyperlipidemia. She says she has about 2 glasses of wine in the evenings. She has on exam, she has a smooth, non-tender liver edge that she can palpate there, but nothing bumpy or worrisome, no ascites, nothing that looks like, edema or any kind of stigmata of cirrhosis. She takes amlodipine for her hypertension, atorvastatin for her dyslipidemia, and she takes a multivitamin, and she takes some milk thistle. And here are her vitals. A couple things to point, and her labs, a couple things to point out here. She does have some elevated systolic blood pressure. You see it's 140 there, even though she's on medication. She's 5'2" and 161, so definitely that could be a little bit better. In terms of her labs, you'll note immediately, I think the first thing I picked up is that her AST is higher than her ALT, so that clues you off to, that's something, either she has more advanced fibrosis or there's, some more, she may be drinking a little bit more, and as well, her total bilirubin is not normal. If we're assuming that she doesn't have Gilbert syndrome or Gilbert syndrome, which is, just that benign elevation of unconjugated bilirubin, if she doesn't have Gilbert's, then this mild elevation of total bilirubin is telling us that, there's some liver damage going on. You'll notice also that she didn't mention it in her history, but she's pre-diabetic, with that A1C above 5.7%. And again, her triglycerides are elevated as well. So we sent her for a fibrosis assessment with a FibroScan with transient elastography. And, she gets an 11.4 kilopascals, so we know that's elevated. That's in that typical range, 9 to 15, that sweet spot telling us that she does have some steatohepatitis with either stage 2 or stage 3 fibrosis. Here on this range, they're saying at the right 9.6 to 12.5 is stage 3. But suffice to say, it's not normal, and she is at risk for all sorts of bad liver things. Looking down at her CAP score, her controlled attenuation parameter, as you know, that talks about how much fat is in the liver, and 310 is pretty high. So she's got fat in the liver and some significant inflammation or fibrosis. So zooming out a bit, you all have probably seen this, but this was in the ASLD republication when we stopped calling things NAFLD and we're calling them MASLD now. And so in this broader category of steatotic liver disease, or SLD, steatosis, of course, just meaning fatty, we are, this was a helpful categorization, I think, because it really inserts these two main bubbles here in the middle, which is just to make us more conscientious of thinking about alcohol intake. So on the far left, NAFLD is now MASLD, metabolic dysfunction associated steatotic liver disease. And I always say, why did we change the name? Because it's so much easier to say. No, it's not. But anyways, we're now talking about MASLD and then MASH, which is that subtype of MASLD that can progress on to cirrhosis and HCC, liver cancer, and bad liver-related outcomes. We know here in the middle, this is ALD, alcohol-associated liver disease. And what we're talking about today is this kind of in-between state, which we call MetALD, where you have both MASLD and, more alcohol intake. And essentially, if you're a woman and you're having 140 grams a week, or that's essentially about 2 drinks a day, or a man and having about 3 drinks a day, that or under is still considered MASLD predominant. And the more alcohol you have, the more it goes on this spectrum to ALD predominant, and kind of in between, in the middle, is going to be what we are calling MetALD. A good reminder, not all alcohol is equal, and we're really looking at grams of alcohol, which you can kind of roughly think about as like ABV, or alcohol by volume. And so, when we talk to our patients, I generally try to have a pretty casual conversation. I say, hey, I like a good drink too. How often are you drinking, and what do you like, and what are you drinking? And just to try to get a pretty good assessment of, are they just having a regular beer? Are they having malt liquor? Are they having one of those high ABV, IPAs that, has like 17% alcohol by volume? Are they having a glass of red wine? Is it a regular 5-ounce pour, or are they having a big glass of wine? I'll often ask them, okay, is it, at dinner, do you just share a bottle, which is about 5 glasses? Are you sharing that with your spouse, or, and who's having more of it? Or are you drinking most of it? And as you get more towards the as to the liquors and fortified drinks, of course, 1.5 ounce vodka or whiskey is equivalent to a 12-ounce beer. And so just be cognizant that about the amount of alcohol in each type of drink when you're talking to your patients. When we're talking about ALD or MetALD, both NAFLD or fatty liver or MASLD, both that and alcohol intake do a similar type of damage in the liver. And when we're talking about MASLD or NAFLD, you've got insulin resistance, which leads to prediabetes, obesity, which you have that excess adiposity in the visceral tissue, which it's not just stored. I tell patients it's not just storage of extra calories, but that extra fat or cholesterol in the adipocytes around your visceral organs is actually acting like an endocrine organ, like your thyroid. It's sending chemical messages that are pro-inflammatory into the body, and there's more and more data now showing that excess weight and obesity contributes to inflammation, contributes to mental health issues, and so that excess visceral fat contributes to this. Eating ultra processed foods and unhealthy foods and sedentary lifestyle all adds to that. We'll talk a little bit about genetics and epigenetics later on a different slide, but also alcohol intake. Also, the alcohol content and the carbs in the alcohol also will contribute to essentially all sorts of bad things in the liver, right? Impaired handling of your lipids, oxidative stress, reactive oxygen species, and that all is going on in the liver, and as well, these will also disrupt the gut and the intestinal microbiome. So sometimes you'll have more alcohol production, ethanol production in the gut. You'll have more LPS and more microbiome-derived products, which will then kind of shower the liver with these bad toxins and increase the work that the liver has to do. And that will increase your inflammatory response in the liver. So all of these things are making your liver work harder than it needs to. On this next slide here, so this was a nice slide by Israelson, and I think this is also Dr. Alex Krog's group. And but anyways, so 3 main points on the slide. So this top box there, the main point of this slide and the whole talk is alcohol bad, right? So in this top 2x3 graph here, you see as you go to the up and to the right, you have greater risks for decompensation. And as you're going towards the right, you're having more and more alcohol use. And as you're going up on this graph, the liver stiffness is getting higher. So, if you have somebody with 15 kilopascals on a FibroScan, but they don't drink a drop, their 5-year risk of decompensation is lower at 5 to 15%, versus if they have ALD and they're drinking a ton, that jumps all the way to 15 to 50%. So essentially, having MASH with an elevated stiffness score is bad for your risk. If you put alcohol on top of that, it makes it worse. So alcohol bad. If you have MASLD and elevated liver stiffness. Again, we are moving to this little second bar here. It is a dynamic spectrum, and I think Dr. Yanasi and in our group, we are publishing some things, trying to get folks to start thinking of, it's not just MASLD fatty liver or alcohol liver disease. We all know in real life, everybody goes through phases, or if people drink, you go through phases where you're drinking more often, and then you're not drinking as much, and then stress happens and you're drinking more often. So in real life, most people are kind of sliding in and out between MASLD and MetALD, just kind of depending on seasons. So I think we have to have that awareness as clinicians to kind of, don't just assume that your MASLD patient that you saw 6 months ago is still MASLD. Ask about alcohol every time and just try to develop a relationship and have open conversations. In terms of drivers for liver disease, these are all things that we have to think about. The number of the amount of, how much alcohol folks are drinking, their cardiometabolic risks. Genetic risks are there as well. So these are 4 of the main SNPs, or single nucleotide polymorphisms, essentially genotypes that have been looked at in the research literature for MASH. We did some study of several thousand patients recently, and PNPLA3 is really the one that floats out mostly in the independent as an independent predictor if you control for the confounders. So right now we're not checking for these genotypes in clinical practice. There are 2 companies, so J&J and GSK, no, J&J and who is it? J&J and AstraZeneca. They do have some trials looking at some, small molecules for people who are PNPLA3 homozygous for the risky allele. So we might see clinical trials and maybe some therapeutics in the future. But for now, for folks that we have that data on, it's not really changing anything. So that's really for the future. But for now, we can address the cardiometabolic risk factors and their alcohol use. Just going back to this, I will say that, if you compare folks with just non-drinkers who have MASLD to folks with MetALD, that is fatty liver with alcohol use, you really do see greater risks for near-term liver decompensation, HCC, so primary liver cancer, and all cancers. So you really do see a lot more risk for our MASLD patients who are drinking excessively. So how do we start talking about this with patients? the main point of the study is you can use both a survey and a certain and some sort of test. So this was 184 patients that were enrolled in several centers in Europe. And so on this box on the left, they assessed all the normal things that we talked about, how much alcohol you do, how much alcohol do you have, what are your risk factors, what's your diet like. And then what they did is they gave them the AUDIT-C questionnaire, which I'll show you in a second. It's just 3 questions that kind of quantifies how much somebody is drinking. And then they did a bunch of other tests that looked at mean corpuscular volume, GGT. They looked at carbohydrate deficient transferrin or CDT. They looked at ANI, which is the ALD/NAFLD index, and some other tests. Mainly what they looked at was ethylglucuronide, so both in the urine and in the hair. And the main point is at the top right. Our NAFLD patients are fibbing, or some of them aren't telling us the whole story. So essentially about a quarter of patients who they thought were NAFLD or MASLD, about a quarter of them had evidence by one of these blood tests or by the AUDIT-C that they were actually consuming more than they reported. And on the bottom there's just some of the area under the curves, just kind of showing that these tests are fairly accurate. Here is the AUDIT-C. So I've started printing this out and just giving it to my patients as they sit in the waiting room for all of my patients who are quote MASLD or MASLD. And it's just 3 questions, really easy. How often do you drink over the last year? When you drink, how many did you have? And how often did you have 6 or more drinks on one occasion? And you sum up those scores there, and 0 to 7 is low risk, 8 to 15 is hazardous or harmful, above 16 is harmful, and the higher you go, the worse. So it's a pretty easy, quick screening tool, 3 questions, and it gives you some way to kind of at least quantify it over time. And essentially that's what I advocate doing. That's what we advocated in our focus recommendations for APPs. But essentially use AUDIT-C if you want, and or PEth testing. So that's what this algorithm here is recommending, and briefly we'll just go through. So on the left, they say, look for your cardiometabolic risk factors, those components of metabolic syndrome. Now, if the patient just has isolated, so if they have hypertension only and, no prediabetes or diabetes, or if they have high triglycerides only, then you might want to consider that there might be alcohol use involved, or they might not be disclosing the amount of alcohol they're using. So if their only component of metabolic syndrome is hypertension or high triglycerides, consider using a PEth test. PEth is phosphatidylethanol. It's a blood test you can do, and that's what I started doing. I tell my patients, we're going to rule out everything else. We're going to check for hepatitis B and hepatitis C and autoimmune hepatitis and all those rare things. And as a part of that panel, I throw in a PEth if I'm suspicious or if I want to. And that's available for by LabCorp and Quest and a number of major labs now. And you can just add it on there. It's a whole blood tube, so it's a purple tube, but you can just ask for it when they go for blood tests. And that can give you an idea. So you want to, here in this, for the assessment of alcohol use, that's what you want to do, is try to quantify the amount of alcohol they're having per week. Try to ask them what their drinking patterns are. Is it just, 1 or 2 glasses a night, or are they binging all on the weekends? And, do they have any history of previous drinking or dependence? And you can consider the PEth test. And so essentially, for MetALD here in the middle, if you're having, if you're having 3 to 6 drinks a day, that's probably going to be MetALD. Here on the right, if you're having more than 6 drinks a day, it's going to be ALD predominant. Again, 6 drinks for a male or 5 drinks for a female. I like to think of it as drinks per day as opposed to grams, but you can do it either way, whatever you're more comfortable with. Just make sure you ask and have a conversation with your patient. Same thing. PEth of 20 to 25 is mildly elevated. That's more consistent with MetALD. And there we go. So here's our patient. We did a PEth test. Her PEth was 120. So that would suggest that she's having moderate to heavy. So that would suggest probably closer to 3 to 5 or 6 drinks per evening, more than the 2 that she was reporting. So you want to try to have a hard conversation with her, or you just try to have a conversation and really assess how much she is drinking. Again, here are some more data on PEth. So I think of PEth just like the A1C for alcohol use. It's going to, any alcohol within the last couple of weeks will show up on a PEth test. And, whereas your blood alcohol level goes up and goes down within, 8 hours or so, the PEth test is going to rise and go on for at least 12 days after a single binge in this study. And again, PEth does not seem to vary much based on sex or body mass. So it's a pretty decent test. This is a study that Dr. Rohit Lumba's group did. And the main point, again, is that some of your NAFLD patients aren't fessing up. So basically, they looked at all their patients in the registry, or a number of patients with MASLD, and they went all the way down to those who had alcohol data. So it was 333 patients that were not, had missing data or whatever. And out of this, 97 had all the alcohol consumption criteria and data that they wanted. And so they ran the PEths on this study on those patients. And essentially, they found that 15% of the patients who they thought were not drinkers were at risk for MetALD and drinking 3 to 6 drinks per day, or having a PEth of that equivalent. So again, have a conversation with your patients and start screening for that. Again, for our patient, she does have PCOS, so she does have some insulin resistance, but no and her A1C was elevated before, so she already is in the pre-diabetic range, and she has both hypertension and hyperlipidemia, and we saw that her triglycerides were elevated. So this is consistent with MetALD. So, the next 2 slides, we'll just talk a little bit about the effect of alcohol on hypertension and high triglycerides. So this was a kind of like a meta-analysis, more like a Cochrane database study, but they looked at 32 randomized controlled trials, and basically alcohol has they found that alcohol has a biphasic effect on your blood pressure. It decreases blood pressure for about 12 hours after people drink, and then after that, it increases the blood pressure. So that it is alcohol use does lead to increased blood pressure over time. And conversely, if you can get your patients to cut down or quit alcohol, it's possible that you may see their hypertension actually improve or resolve, just depending on how much alcohol they're drinking and how it's affecting them. We've got 2 minutes. Same thing with high triglycerides. And this was a study where this top bar is people with existing hypertriglyceridemia. This bottom over here is people without that diagnosis. And essentially, in the blue, if they drink alcohol, it bumps up their triglycerides over the next 10 hours. So wow, I talk long. So, but this is our patient. So essentially, I would just tell her alcohol is bad. You've already got components of metabolic syndrome, and you are at risk. Folks with MASH, you are at risk for getting liver failure, cirrhosis, and within the next, some of them have that risk within the next 2.5 years. And if you add alcohol to that, every drink that you have, it's just increasing your risk. So we really need to make some changes. She has, MetALD. So what do? We talked to her about diet and exercise. She would be, she does have MASH and would be a candidate for resmetirom. If I were to treat this patient, I would tell her, look, we can use this resmetirom to help your MASH, but you really need to do something about the alcohol. And, I would point her to our different alcohol substance use folks and just say either you need to quit completely, or go dry for 6 months or 3 months, whatever you can do, or cut down significantly. And as I mentioned before, people with MetALD, MASH with alcohol use are at even greater risk for HCC. So, given that she has a significant amount of fibrosis, and I would recommend starting to screen her for HCC using ultrasounds every 6 months. So we're going to skip this, but essentially the main thing is saying that as we move forward, we should try to assess whether patients are drinking alcohol by using something like PEth in clinical trials. And here are your take-home messages to finish this out. So start thinking about MetALD. If men are having more than 3 drinks a day, if women are having more than 2 drinks a day, that's probably closer to MetALD. And you can document it. There's no ICD-10 for that I can find yet, but just you can start documenting that way and just having a different set of risk awareness for these patients. You can use the AUDIT-C test and or PEth. PEth is pretty easy. And you want to ensure that the drivers of liver disease are present over time. So as I mentioned, if they can cut down their alcohol, the triglycerides and or their hypertension might improve, and then those things may not be something to consider. But the main point of this talk is 1, 2, 3. Alcohol is bad. It increases all your risks. Ask your patients about it. Have good conversations. Get comfortable with that, and you can use PEth and AUDIT-C as a way to kind of quantify their alcohol use. So thanks for joining me. You can use this QR code to learn more about our MASLD community network, and to get more education, connect with other thought leaders from GAP, and for the Resdifra webcast. So thanks, and scan this code if you want to do a quick survey. Thank you for joining me tonight, and we will see you at the next meeting. Take care.